So, hello everybody and welcome to QI TalkTime today. We're broadcasting with Eleanor over in Canada, so we're delighted to have her on board with us. And thanks for taking your lunch break out to come in the nice sunny weather to come join us today. So today is about partnering with patients, accelerating quality and safety improvement. So just a little bit about Eleanor. So Eleanor is a senior healthcare advisor with 35 years experience in Canada. She's a paediatric nurse. She's a proven track record in leading change to improve organisational performance, and it has been strengthened by her keen interest in patient and family-centred care. She enables patient and provider partnerships to inform planning and decision-making about healthcare, partnering with other organisations, for example, the Canadian Patient Safety Institute. So just a little bit about the webinar and how to use it. You'll see in the top right-hand corner of the screen a chat icon. So just to try and make it interactive, if anyone has any questions or answers, or questions or comments throughout Eleanor's talk, you can put it into the chat box and we will have time at the end for those. So please do keep it as interactive as possible. We also, I have here beside me, I have Greg Price, who's working with Eleanor and partnering with her, and so he's leading up the Irish, I suppose, patient engagement part of the HSC. So without further ado, I'm going to hand over to Eleanor. Thanks very much.
Great, thanks, Rosine, and thanks to all of my friends and colleagues in Ireland for this opportunity to be part of this network. I think it's a wonderful innovation and hope to sort of continue work in the future. So this morning, or this afternoon for you, we are going to be talking a little bit about partnering with patients and how I have experienced this to really be an accelerant for quality and safety improvement in our system. The first sort of slide I want to share is one that I found fairly recently, and to me it really underscores the value of partnering. And it's when I is replaced by we, even illness becomes wellness. And what I like particularly about this is that it can speak to illness and wellness at different parts of the system. It can be that focus on health and prevention and treatment at a patient level. But we also know that we struggle with the wellness of systems, and when you enter into partnering to influence the design and the way those systems are implemented and evaluated, that actually leads to healthier units, healthier organizations, and healthier healthcare systems. So I'm going to speak a little bit more about why this really resonates so well with me. What we are going to be looking at is the distinction of patient family-centered care from engagement and partnership. So by the end of the presentation, I'm hoping that we have a shared understanding of what today we are talking about with those definitions, but also what are very reasonable expectations of both the organizations and of patients and families as we move into that partnership. And very importantly, I think it needs to be recognized that patient family-centered care and engagement is a means to the end of quality and safety. I was sharing with Greg last week that very recently I was in an organization where with really good intention they were saying that if they have to choose between quality and safety and partnering with patients. So if they had to put energy or resource into one or other of those initiatives, they would say they would always have to lean toward the quality and safety. But it led us to a very, I think, important discussion that the process of engaging and partnering with patients and families actually is the means to the end of attaining quality and safety. And so it really shouldn't be a decision of whether it is one or the other. It's how to approach both and do both differently. So first, to focus on the definitions of what we're talking about, because often the terms of patient and family-centered care, patient experience, and patient engagement get thrown around and tumbled together, and they really mean very different things. So the core values of patient and family-centered care are illustrated on this slide as defined by the Institute for Patient and Family-Centered Care. And they are respect and dignity, information sharing, participation, and collaboration. Don Berwick, who is one of the true, I think, global experts in patient family-centered care, defines it as the experience to the extent the informed individual patient desires it, of transparency, individualization, recognition, respect, dignity, and choice in all matters, without exception, related to one's person, circumstances, and relationships in healthcare. So it's a very, very big definition, and he has reduced it to, in different discussions, sort of different maxims, but I think the one that really has resonated at an international level is the one, nothing about me without me. And it only by engaging with patients can you determine whether you are meeting this definition of patient and family-centered care. It has been defined it has been modified in Canada by different organizations, but the one that I'm showing right now is the definition that Accreditation Canada has landed on, and that is an approach to care which guides all aspects of planning, delivering, and evaluating services, with the foundation being mutually beneficial partnerships between patients and families and service providers. I think what's very important is not necessarily what a specific definition is, but what's important is for every system or every organization to make sure they know how they are defining patient and family-centered care, and that they use that as a definition and always refer back to it to ensure that they are delivering on their own expectation. So just to go into them a little bit more, this is patient and family-centered care typically is defined as an overarching philosophy or approach that ensures that everything individual providers or healthcare organizations do is clinically or administratively based on the patient's needs and preferences. So there are many ways to achieve that. It can be at the direct care level or at the system level, as I've described. Patient experience differs in that it is how patients perceive and experience their care. So sometimes how we think we are delivering care or what we get as outcomes are very different than how the patients perceive or experience that. And to really understand experience, it really involves that ability to hear what's being said and to measure that experience, and then develop the capacity to use the information that you gather to change practice and change policies or change roles within the organization. I think this is a slide that was shared with me with one of our advisors, and I think it really defines that. And we know that people will often hear what they say, but the meaningful and the experience will come from what they feel out of what is said or done to them. Then I want to sort of look at the patient engagement and partnering aspect. And I think this is a very important change that has evolved in healthcare over the past 10, 12 years. And patient engagement is really looking at stewardship in healthcare in a different way. And typically that we have been very proud of the way that we have provided care or worked with doing things to patients and doing for patients, and always with very good intention and with great expertise. The shift over the past decade has been that mindset of doing with patients and families. So it really changes and moves into a spirit of partnering and looking at shared goals. To look at some of the definitions, these are definitions that are used by Accreditation Canada now. So patient engagement is the way in which individual providers or healthcare organizations solicit patient needs and preferences and ensure that they are delivering patient-centered care. So the only means of soliciting needs and preferences is to be moving into some sort of engagement, whether it is information sharing, consultation, or partnering at a very decision-making level. Partnering is that arrangement in which two individuals or more share the profits and liabilities of something. So that's a very business model of definition, but it actually can be translated to healthcare. So it's an arrangement where parties known as partners agree to cooperate to advance their mutual interest. So it will be defined by many things. It can be defined by overarching goals. It needs to be influenced by a level of give and take. There needs to be clarity around responsibility. It doesn't mean, we often talk about equal partners, but that might be in the profit sharing or the mutual benefit. But what people will bring to the table will be different. So they will have specific areas of responsibility and expertise. It often needs to be determined by the lines of accountability. At some point, there has to be a decision maker, or it has to be agreed that decision making will be shared. But those lines of accountability need to be very clear. And it also needs to be clear how success is going to be evaluated or distributed. So this is where it's very important to understand what's expected of each partner. A very key part of the partnering is that notion of sharing and understanding information. And this is another slide that was shared by an advisor. And it's basically saying when you talk, you're only repeating what you know. When you listen, you will learn something new. And that new knowledge is what is going to influence what the decision makings are or the plans moving forward. So looking at what partners bring to the table, healthcare providers bring clinical expertise. They may bring administrative expertise, how to navigate that system, and that system knowledge. And what I think is important in terms of this notion of partnership and sharing is it's also key for healthcare partners to be sharing and acting as partners in the same fashion between and amongst themselves. So as teams, there has to be that equal respect of what is brought to a table that is new and is going to be listened to and shared respectfully. So healthcare providers bring clinical expertise, administrative expertise, system knowledge. Patients and families bring their experience of illness or their previous experience of wellness. They bring their experience of themselves and what's important to them, what their cultural background is, what their beliefs are, and what's important to them. And they will also bring their experience of the healthcare system and the providers. So they will know what has worked well, what has not worked well, what they don't want to have changed, and where they see opportunity for things to be influenced differently. What I also think is what I liked about the graphic illustration that's been included in this slide is I think it's also very important for healthcare providers and systems to recognize that the journey of the patient is much different than their encounter with us. We are merely one stop along the way of their experience. So I often like to think that within a healthcare system, we might represent those 4 buildings, and that as a hospital, we might represent one of those 4 buildings. But we are one moment in their long story, and if we don't recognize the importance of hearing their story, then we are at risk of not delivering that patient and family-centered care and not engaging in the most meaningful of ways. So when you begin to put those together, you get the richness of what can be brought to a table, be it at that direct care level of a direct patient encounter or at a system or organizational level. The maxim that's at the bottom of that slide, respect me, hear me, and work with me, was actually the short definition that the Patient and Family Advisory Council that I first worked with at Kingston General Hospital created to support what they were expecting of the organization. So they were saying to us, respect me, hear me, work with me. And that's what they wanted. What became quickly apparent as this unfolded within our organization is actually that maxim applies to everyone that is at the table. So it can be said just as much by the clinicians or by the administrators in the system as it can be said by the patients and families. So clinicians want to be respected, heard, and worked with, just as patients and families do. But to me, it became a really resounding call for that partnering. And so when you bring this all together, and this is a slide that I learned from Angela Coulter, is that when you bring all of that together, it has that experience of bringing the different perspectives, but it will lead to better information, it will lead to better decisions and better outcomes. And again, that can be at many levels, but all of those are going to be the things that ultimately influence that quality, the safety, and the experience. And we'll talk a little bit more about that going forward. This slide shows what is referred to as the Carmen framework, and it's the culmination of work done by a team led by Carmen. And you can go into the article and get much more detail. The citation is there, but I include it to really illustrate that engagement actually doesn't have a single way of doing it. It can be along a continuum, and it can involve consultation, it can include sharing of information, involvement in design, or it can extend to very detailed and formal partnerships and relationships of shared leadership. It also can occur at many levels. It can be at that clinical care level where it's the provider and the patient. It can be at an organizational level, and that could be at a unit or a program level, service level, or at an organizational level. And then it can also extend into a system or policy level. And I think what's important is that there's no specific desired location to be on this grid. I think what's important is to, as providers or as organizations, to look at where are you in the nature of the engagement and the level of engagement, and if you want to change something, where might it be that you want to go, and then to look at what the strategies are that can carry you in that direction. So this all means that shift from leading with, partnering with, and partnering with patients and families. And some really wonder whether this is sort of a fad or the flavor of the month initiative, and that's just going to pass. And if you wait it out, people will move on to the next thing. And I think it's important to look at just how embedded is this becoming in our work and in our system. Again, Angela Coulter had this quote in 2014 saying, I think there's recognition that paternalism is the past, and the future must see patients recognized as partners in their care and experts in their own conditions, an ambition to which clinician and health service managers regularly pay lip service, but which has yet to be fully realized. And this actually, again, resonated with me in the organization I was speaking about, where they were talking about everybody recognizes the importance of this and they talk about it, but it's not being translated into actions and behaviors within the organizations. And I actually had the chance to meet and speak with Angela Coulter in February of this year, and I asked her whether this definition would still be as clear today as it was in 2014, and I think there was general agreement that this pretty much applies today as well. So it's important to look at what's going on in the current healthcare landscape that might dictate why this is still such an important notion. And we know that we are living in a climate of economic challenges, political uncertainties and change, influence within that health system redesign. We definitely have change in customer or consumer mindset. If healthcare providers choose to sort of have that ostrich syndrome and stick their head in the ground and pretend this is either not happening or is going to go away, they need to be aware that patients and the general public are acutely aware of this and are looking for it within the system. And it's also that the fact that they have that very far-reaching and immediate access to information. So when people come into the system, again, regardless of whether it is at that direct care level, system level, or organizational level, they're able to access such broad and deep information within the internet that we can't hope to be ahead of them in terms of the information that they have and the depth of their specific interests. So that far-reaching information actually needs to be recognized as an asset and a tool, and it leads to that notion that patients and families have actually been the greatest untapped resource within healthcare to date, and increasingly people are looking at how do they tap into that knowledge and expertise. The drivers at a global level, the World Health Organization last year had a signing of a strategy on integrated people-centered healthcare services. And Ireland is a signatory to this strategy, as is Canada. And my understanding is, was universally endorsed by all countries in the World Health Organization. So at a global level, there is a directive that is influencing the expectations of people-centered care and of partnering. Definitely within Canada, we've got many drivers, but definitely within Ireland, you have taken that step of making the commitment to improving quality. So that framework for improving quality issued by HSE is definitely a stake in the ground and is going to define how Ireland moves forward. And very importantly, within that framework, there is the Declaration of Person and Family Engagement. And the Mayo University Hospital in Castlebar is one of the system partners in Ireland that is becoming the lead and the exemplar within Ireland in terms of this work. And so they're doing some very exciting work that is going to have that field of learning and then that opportunity for spread. So it's a very bold strategy and one that is going to determine how things unfold in your country, just as there are similar drivers within Canada influencing ours. Within Canada, again, we've got many organizations that at a national level are determining how patient voice is being brought to the influence of quality and safety and outcomes. And so these are just some of them, and you will know in your country which ones are sort of the partner or parallel organizations. One that I think was very interesting that is more recently coming online is the fact that academic institutions in their strategies and missions and values are also identifying that importance of patient-centeredness. And one of the academic institutions that I have worked with and follow is Queen's University. It's our local university. And they have just, in their strategy for the Faculty of Health Sciences, indicate that they are going to keep patients and populations at the center of their academic mission. And they actually, one other organization I was in, talked about how they actually are having patients and advisors now on the hiring committees or the selection committees for the residents that are going to be chosen to work in their organizations. So I think that the fact that we have got academic institutions who are the educators of our future care providers putting such a stake in the ground around patient family-centered care actually speaks to also how our clinical settings are going to have to ensure that they're having environments that support the knowledge that these learners have. As I mentioned, Accreditation Canada is a huge driver in Canada around better quality, better health, and organizations here invite Accreditation Canada into bringing in an assessment against proven standards for quality and health. Accreditation Canada is also, or HSO is the organization that is partnering with Mayo University with their work on patient engagement. Their definitions, as I mentioned, is always looking at in partnership with client and family, and they define this as a team, any team within an organization or a community health setting looks at how they collaborate with each individual client and their family to deliver care services. And clients and families are as involved as they wish to be in that care delivery. Now, the thing about that is the only way you will know how much they wish to be involved is to have that discussion to determine that degree of engagement. With input from clients and families is looking at how input is sought collectively, and that can be done again in a variety of ways through advisory committees, focus groups, surveys, informal day-to-day feedback. So it can be gathered in a variety of ways and at different times, but it must be utilized by the organization. That's what the test is against this expectation, is how then is it gathered and then utilized. And I'm not going to go through all of these points because the slides will be available to you after so that you can get into some of the detail. But basically, Accreditation Canada has set out some very high-level expectations that include having client and family-centered care as a guiding principle for the body that is being accredited. So it may be a organization, it can be a healthcare authority, it could be a community-based clinic. It also looks for co-design with providers and families. It looks for creating the structures and cultures that basically create that environment for implementation spread of client family-centered care. And it includes very direct involvement on advisory and planning groups. At a clinical level, it's looking to see how clinical teams include patients and families as part of the team, and that they partner with patients and families to ensure that they understand what participation in their care can look like, and that they respect the client choice about their involvement in care. It's not done in that paternalistic way that Angela Coulter referenced, and that there is monitoring and evaluation of the services with input from clients and families. So what I want to go into now is how at an organizational level, when I was working at Kingston General Hospital, we learned how our implementation and spread unfolded. But as I've worked with other organizations as a surveyor with Accreditation Canada or in partnership with such organizations as Canadian Foundation for Healthcare Improvement and with different consultancies, what are being seen to be the things that really set organizations up for success to partner with patients and families. The first is to have a strategy. And at Kingston General Hospital, this was the strategy that we developed, and it guided 5 years of work within the organization. The strategy itself was developed with patient and family input. And then it basically created the expectation that patients and families would be involved in any discussions and decisions that would have a meaningful impact on them. The first strategic direction in this strategy had the declaration to transform the patient experience through a relentless focus on quality, safety, and service. And it included principles or values. So most organizations will have mission, vision, and values. The values that we included, which were described or defined as principles were respect, transparency, engagement, accountability, and value for money. And those values were expected to drive the behavior of every individual every day within that organization. And you can see how those values, respect, transparency, accountability, speak to and resonate with the values of patient and family-centered care. Oh, I'm going to exclude that one. Sorry, that was not to be there. Within the winning conditions, what it also meant is that within Canada, within our KGH strategy, not only do you have a strategy, often strategies get developed and then they get put on the shelf and nobody really refers to them or makes them live and breathe every day. What we ensured is that that strategy influenced the annual plan every year, and every year we had stretch goals that would sort of take the organization forward in a very meaningful way. And every quarter we would report on what was going on with the annual goal. So that corporate strategy, which was a 5-year strategy, had a new plan every year that had a new initiative that would be measured, and it would be reported on a quarterly basis minimally to the organization, to the board, and to the community. And to transform the patient experience, you can see in this slide, we had that we would, in this year, drive the overall patient satisfaction to a level that was beyond the teaching average within our province. And this involved initiatives such as looking at what would we define as 5 measurable strategies within the organization that we could measure each month and then work on to make sure that we were improving communication, that we were improving the engagement of staff and patients. We created patient-led forums, which would be where patients would come back, share their experience with the care team, and then with that care team identify whether there was an opportunity for improvement, and then design the change, implement it, and evaluate whether it had made an improvement to that unit, and if those strategies worked, we would spread them within the organization. But all of it was to say that the strategy must be translated into plans that are measurable, and to deliver on those plans, there need to be very specific tactics that can be measured and demonstrate that they are actually making a difference. We also needed to ensure that there was leaders and leadership support. So there were positional leaders that were very directly involved, and Leslie Thompson is the lady on the left, and she was our president and CEO, and became a very clear champion for what was going on within the organization and sharing it at a national and international level as the value and successes became known. The lady on the right was our first chair of our Patient and Family Advisory Council, and we really very much took the position that when we would be speaking about this work, we would always ensure that we had the voice of a patient at the table to always ground the importance of that partnering in the work. I think was so very clearly champions, and I think what's important is that these were positional leaders, but it's also important to tap into the organization and look at those who have leadership by behavior. And this slide, I think, shows that their leaders do not always have to be positional leaders. There are behaviors that can be demonstrated that really reinforce what leaders do, regardless of whether they have that formal title. Some of those behaviors are going to help you identify who your organizational champions are. This gentleman, his name is Daryl Bell. He was the individual within the organization that became a very key basically that middle line leader within the organization who connected to the senior leadership team. I was the executive sponsor within the organization for this. Daryl was a key partner with me and with the Patient Family Advisory Council, and then with those partners at the organizational level, the directors, managers, who could take this into the organization. And the organizational champions, to me, are those individuals who truly have that knowledge and passion about patient family-centered care and partnering, and who have that resolve and tenacity and truly relentless pursuit of ensuring that the organization understands and then influences behaviors through this. And what I will say is that the organizational champions do need to be relentless at the outset, because in our experience, when we were doing this, we had to push this into the organization for about 18 months. You know, there were the few that, it was the converted few, and we really had to push. After about 12 to 18 months of pushing this into the organization, what we found is then there was an understanding and an appetite and a shared resolve and passion within the organization. And then everybody started to come to us to say, okay, we need this. Can you help us get advisors? Can you help us with this work? And then we began to respond to the demand. So the first part of our work was creating the demand, and then the latter part of our work was responding to it. A big part, and that I wanted to include this one because, and it's to that point that there is that push. When you start this talk, everybody will sort of, again, give it some lip service, but then as you try to make the change, the enthusiasm may dwindle or not be quite as robust. And then when you get into who's going to lead it, then you're into a whole different game as well. But I do want to assure you, with following through on this, that does change. So a big part of it was actually having the partners, and these are your patient family advisors. And some of these individuals will come into that formal role of partner. They may be, what you call them within your organization, again, will need to be determined by you. But it is really the importance of having patients and family members who understand your system and who want to work with you to make it better. I think it's important to distinguish advisors from advocates. And that was something we learned fairly early on. Advocates tend to have a very clear notion of what they want to change and what that change will look like, as opposed to feel like. Advisors are those who want to come to the table, and they will bring their experience to the table and be with you as you co-design with them what the change might look like. So there's not that notion of what the next step will look like, but there's that willingness to be at the table with you and be part of designing it. How you get that feedback, again, can happen in many different ways. These are ways that we've identified, or others have identified and very beautifully graphically demonstrated as ways to get patient input. And some of them, as I say, can be through that formal advisory role. I think the important thing is to understand your own system or organization or unit or relationship with patients, and then be creative and define it from there. Within an organization, definitely what we learned is that we needed to have that performance improvement mindset. And this meant really attending to all of the things that are necessary to support change, and to be able to know that as you make change, that you actually are making the change that you intend. So the things to be very mindful of here are education. You do need to ensure that those that are going to be supporting the work actually have the knowledge, and this involves the breadth and the depth of knowledge to be able to oversee change, to be able to help explain and teach it to others, and to continue that inquiry and expansion of knowledge. It differs from communication in that communication is making sure people have an understanding at a very high, sort of that elevator speak level of what is being done, and that they know how they need to support it, and that they can watch. It creates that awareness, not necessarily at the same level of depth and breadth as education will provide. It also is that attention to project management. It means that there have to be plans in place, and somebody needs to be watching what the actions are, what the responsibilities and accountabilities are, who's doing what, when is it going to be done, and how does everything knit together so that you can keep everything moving along in a very systematic way. And then the other part is looking at that performance management and monitoring. The only way you're going to know that you hit the mark is to know what it is you're trying to change, how you can know whether you've changed it, what are going to be the measures. They can be outcome measures or they can be process measures, and then watching, monitoring, and reporting on those to know whether you make the change and whether you sustain it. There needs to be infrastructure to support patient family-centered care and engagement. And there are many things involved in that infrastructure. That could take a whole other webinar. But it's things like having role descriptions for the advisors and role descriptions for staff, terms of reference, policies. You need to have space for advisors. Having space for advisors becomes a very meaningful declaration of an organization that this requires that resource and that they're being supported the same as others within the organization are supported with space. There needs to be what I spoke a little bit earlier about, that patient-centered leadership where it's behaviors every day by every individual, where they're thinking through the lens of what is the experience. So you're assessing through that lens. It also means when data is being presented that you put it in the context of what the patient experiences. And the one illustration that we find really helps with this is when we look at that, trying to move the bar on patient or on hand hygiene. And often, hand hygiene rates as a measure of preventing nosocomial infections within hospitals were low. And we realized that was a simple strategy, like improving hand hygiene was a strategy to move that, that bar on hospital-acquired infections. And so we would often celebrate coming from hand hygiene rates of 50 or 65 and celebrate bringing them up to 80%. However, if you take that 80% and say, well, that's 80% out of 1,000 is 800 staff have washed their hands. But you change it and put it in the lens of the patient and say, we're celebrating 80% hand hygiene rate, which means that we're celebrating that 200 patients, or 20% of the patients in our hospital, had an encounter with a healthcare provider who has the knowledge and the skill and all the tools to wash their hands, and didn't. It all of a sudden changes the discussion and makes it easier to say, how do we get it to 100% compliance by staff and 0% exposure of patients to an episode of not having their hands washed. So those are the things that get translated by assessing through patient lens, including them in the strategies, sharing the success stories, and learning from them. And then it's always looking at sustainability. So part of sustainability is looking at all of the things that we've just talked about, but really importantly, celebrating the gains, but celebrating them in a way that keeps the lens on the patients and families and their engagement with you. So I'd say the winning conditions get summarized as those. And if you go into different literature on sustainability, you will find that much of this can be presented in different ways. So there's no secrets to the success. It's a result of preparation, hard work, and learning from failure. And a lot of people think it's pretty easy, straight line, and what I would want to underscore is it's much more complex than that. And you have to be sensitive to the resistors of this. And the resistors are going to come at many different points. They could be bureaucratic. They're going to be individuals. They're going to be individual groups. It could be by position. It could be technical barriers. Like one organization, the patients and family advisors wanted equal access to the web accounts, where the people that they were on committees were getting minutes and materials in advance of a meeting by their internal web, but the advisors didn't have access to it, so they were provided materials at the table. They weren't on a level playing field by doing that. So sometimes just technological barriers. The challenges can be many. As I said, language can be one. There's going to be skepticism. There's going to be, you have to look at the scope and pace of change that an organization can sustain. There are going to be long-held practices. In one organization I was in recently, again, the response I got to why something was done is, well, that's the way we have always done it. You have to ask the next question and say, why was it done that way then? What's changed, and how do you move forward? Absence of research was a huge barrier when we were starting. It was show us the evidence, and then we'll listen to you. Not all of this requires scientific literature. There was a lot of gray literature at the time, but now there is much more research, like scientific research that actually underscores this. Really big part is keeping it authentic and not having it become token. If you have a patient advisor at a table and that advisor is never invited to speak, never speaks, and it's just that checkpoint, then there's something very wrong with the design of that engagement. And I think the very important thing is to not expect great things immediately, but a little bit of progress each day adds up to big results. When we were being consulted initially about our work, our comment was, we used more the Nike slogan and said, just do it, like just get started. Bring patients to the table and see how it influences and changes the discussions, and you will absolutely see the value. But those small steps are key. The value proposition is critical to understand. There's value to the organization, and this comes through in many ways. And these are important things to identify, and again, the literature extols many of them. But, you know, there's the improved care coordination, there's lower operational costs. As a result, the staffing costs actually get changed, because much of this work in engagement and patient-family-centered care leads to a better work environment as well, and it connects staff to why they came into healthcare. And we found that actually our staff turnover rate decreased, sick time decreased, overtime decreased, and our recruitment was successful, and staff who were being recruited said they were coming to the organization because they saw and felt the commitment to patient-family-centered care and partnering. So it actually, it made the work environment wholly different. So there are many values to that. And so some of those are listed there. I won't go through them because you'll have them as reference. Very importantly, there's a value proposition to patients and families. And these include the decreased anxiety, the improved information exchange, which leads to better care planning and better understanding of the patient, decreased critical incidents, like you'll see patient falls decrease, you'll see medication incidents decrease, you'll see avoidable recovery, like the engagement to have decisions about end-of-life care and interventions will lead to different decisions that are aligned to the patient wishes and different use of hospital resources. There are very clear directives. Greater satisfaction ratings. When I said we wanted to go in our organization to exceed the teaching hospital average, that was accomplished within 3 years, and we were below. And the other part is that it will lead to the wish of patients and families to become increasingly engaged, and it also at a point can lead to the giving back in material ways. I've included in this slide a number of tactics that unfolded within our organization that related to people, to technology, and the environment, and to processes. I won't go into those in detail. Again, you've got them as reference. The important thing is in considering, and this is a question that should be asked of any staff, is what we do meaningful, respectful, efficient, and integrated? Is the client and family voice at the table? Is it influencing the discussion, indirectly or directly? How have we used their input? Are they engaged throughout the organization? Are we supporting with education, training, information? And that's for advisors and staff. Do we tell stakeholders how their input impacts care and service? We know a key piece to engagement of anybody, our staff, physicians, and advisors, is they have to have the communication as to how their input has been used and valued. And then can you provide the evidence that you are client and family-centered care? The lessons we learned were not to oversimplify or underestimate the complexity. Always connect the dots from what is being done at the front line, direct care, to the organizational strategy. And that ensures, it requires that thread of communication from direct line to board. Engage stakeholders early and frequently. Listen and learn from the staff, from the patients and the advisors, and from the knowledge you gain through objective monitoring. Be flexible, but don't compromise. It's not if you're going to do this, it's how you're going to do it. And you need to have that patience. Change takes time, and complex change takes more time. And very importantly, celebrate and share, and start that celebration early and share broadly. Don't underestimate the complexity. A lot of times, if you make it look easy, people will think it's easy, so be sure that you focus on all the things that the people do not see and that are just as much of what must be celebrated. So they always say that there are three, if you work in and with sort of that three messages, you can land a final message. So I have extended that, and I'm using three groups of three. If you bring together knowledge, experience, and instincts, and respect that no one person is likely to have all of those in the measure that's necessary for change, then you will be looking at how do you partner with others. If you use that knowledge, experience, and instinct, you are going to influence change in culture, processes, and outcomes. And those outcomes are going to be your safety, quality, and experience. So then the question comes to, should we, can we, and will we? And from my experience of the limited work that I've had with Ireland and with HSC, is that the country is definitely in, yes, we will, and what they're doing is appealing to all partners within the system to share that, that commitment. And so it really, I want to go back to the first slide again and hope that you see why I feel so strongly that when you replace I with we, that it is going to lead to a wellness at a patient level, staff level, organization level, and system level. So at this point, I'll hand it back to questions, and I know I've got a wee bit over time, Rosine, so I'm hoping that there's still time.
Thanks very much, Eleanor, for a really fabulous talk. Certainly a very challenging area, and you've provided everyone online with loads of content there, and thank you so much for all the effort you put into your talk. So if anyone has any questions, please do put them into the chat box function. At the moment, I think your talk was so clear, we don't have any questions, but Greg here beside me would like to ask you one, if that's okay.
Okay.
Eleanor, just a couple of comments first. Really thanks again for a very inspiring talk on the whole area of patient engagement. When I heard you speak before, you talked about this being a game changer for Kingston General Hospital. Can you tell us what Kingston was like before all this work happened there?
Right. Very good question, Greg, and it's a story that we're always selective about how we tell, because before we began our work on patient family-centered care, we were actually an organization that had quite lost the confidence of pretty much everyone. Our patient satisfaction, as I said, was not great. Our outcomes could have been better. That wasn't the biggest part of our concern. We were financially bankrupt. We had lost the confidence. Our staff morale was very low. Our community, as we did our strategy, we learned our community did not feel safe and wanting to come into our organization, and we had definitely lost the confidence and reputation at our government level. And we had gone through a period of first investigation, which is when the government believes that there's such a problem that they need to send someone in to very objectively assess the organization, and if they believe there are sufficient concerns, they put in a supervisor, and that's what happened. And so we were at a very, very low point in terms of our healthcare system. And so there was a change in the leadership, and that change in focus on the strategy, which was so informed by patients, by staff, and by our community. And it made that really resounding commitment to change that experience, to transform it. And we began our work, but as we were doing that work, in our organization, again, with that really good intention, we were going to design it, we knew what the problems were. We landed on, why don't we bring some of the patients who have had such a worrisome experience in our organization? And we had 3 at the outset who agreed to partner with us. And when they did, it was bringing them to the table. It's everything we thought we were doing well. They would say, that's not the way it's working. Or, you know, as much as you have good intention in your design, it is not unfolding that way, and it's actually not even what we want. And so when we talked about it being a game changer, it shifted our lens. All of our discussions changed. When you have patients at the table, you know that clinicians and administrators are going to use different language than perhaps they have used before those patients were at the table. So it immediately begins to change the discussions, not only the content and focus, but the way people talk. So you begin to influence that respect, you begin to influence that spirit of partnering. And we believe without doubt that it accelerated our ability to deliver on the turnaround plan that we had submitted to the ministry. And some people, when we began to talk about our work with engagement, said, yeah, well, you guys were so bad, you had to do that, that's not our problem. And our encouragement was never get to where we were to learn the lesson and to gain the appreciation of the value of partnering with patients as we did.
Thanks a million for a great answer there. We have actually had a few questions on the chat box, Eleanor. One from Nicola, who asks about cognitively impaired patients with little care or input, and have you any tips on how you might engage them effectively in their care?
It's a great question, and I think it's why typically the reference will be to patients and families. So I think wherever there is a challenge with engaging directly with the patient, for whatever reason that challenge might exist, then you look at the family, who typically will be very engaged with that individual, and they become that voice of experience and perspective. And always family is defined by the patient. So, you know, we always said that some of us, it might not be our bloodline or legal line that we want as our voice in some of these initiatives. It might be the person, dear friend, that knows us best. So family is always as defined. The other thing I'll comment about with the advisors is we learned from partners in the States that we were working with that we learned from their statement that your advisors should look like your waiting room. So if you are selecting the people that you know are going to be your cheerleaders, or who you think are reflecting a certain certain sector, then you're introducing a bias. The goal is to have your group of advisors reflect your waiting room, because that's the way you're going to know whether you're meeting your patient population needs.
Okay, great. Thanks for that. Just one other question before we finish up from Grania. She was asking about how high up the organisation in Canada are patients involved in their care, in discussions, I suppose. Is it at policy level, is it at government level, or is it just at individual institutional level?
Well, in Canada, it is at a policy level, like a government and policy level now. Certainly within organizations, I can't cite an organization right now that has a patient advisor on the board, but I believe that is unfolding almost as we speak. But advisors have definitely been involved in the quality committees of boards of organizations. At a government level, within Ontario, we have our Ministry of Health, and then there's a group called Health Quality Ontario that advises on health quality. And that organization has advisors as part of its team and board. So that engagement is very much, and the national associations that I listed on that one slide, those organizations definitely partner very much with patients and families at a leadership, high decision-making level.
Okay, great, Eleanor. Just conscious of time, I think we'll finish up there. And thank you so much again for giving us your time and energy. Thank you very much. There's a lot of comments coming in that it was a great presentation and people have a lot of food for thought. So just to let people know that the next webinar, we're taking a little summer break for the month of July, and the next webinar will be on August 1st, and it will be on having an effective coaching conversation with Liam Fallon. The details of that will be up on the website, as will today's recording and slides. So thanks everyone for joining again, and thank you, Eleanor, very much. Okay, thank you.